It's a bumper package, and we have great speakers. So permit me to present the first speaker for today. He is Dr. Kingsley Agholor. He's one of the few guys around us that is IOTA certified. And it's one of the things that we all can also achieve. He will also tell us a little bit about IOTA. He has attended many other courses and conferences around the world. He's a prominent member of the ISOC 3D focus group, and he's also a member of the IOTA group.
So I believe that at the end of this presentation, we will understand, have a better understanding of the physics of transducer choice, and then we also understand how to systematically perform the transvaginal ultrasound examination using standardized probe movements. I will also appreciate the principle of probe orientation and image orientation, while recognizing the importance of image optimization. The main goal, of course, is to produce high quality gynecological ultrasound with a view to improving women's health. When we perform a basic gynecological ultrasound scan, we expect to visualize the cervix and the uterus in both the longitudinal and transverse plane, determine that the uterus is anteverted or retroverted, and of course, take measurements, including measurement of endometrial thickness. We should be able to assess the ovary, determine its size, describe the morphology, and recognize the presence or absence of fluid in the patch of Douglas. And we use the information so obtained to distinguish the normal from the abnormal. A gynecological ultrasound can be performed in two ways, abdominally or vaginally. When we perform an abdominal scan, the distance between the probe and the organs that you want to see, the uterus and the ovaries, is long. So we work with low ultrasound frequencies. That gives us quite poor resolution. Hello? Hello, can you hear me? Can you hear me? Sorry, I was just told I was off. So I was saying that when we perform organs that we want to see, the uterus and the ovaries is long. So we have to use low ultrasound frequencies. This gives us quite poor image resolution. On the other hand, we have good overview. So we can see the uterus and one ovary, and sometimes the uterus and one and two ovaries in the same image. When we perform a vaginal scan, the distance between the probe and the organs we want to see, the uterus and the ovaries, is just only a few millimeters. So we work with high ultrasound frequencies. That gives us superb resolution. On the other hand, we have poor overview. We can only see one organ at a time. That's really what we want. Seeing one organ at a time, focusing on that organ, enabling us to do a detailed analysis. So the poor overview turns to an advantage. Another advantage is that the discomfort of a full bladder is eliminated, because when we perform a vaginal scan, we require an empty bladder. A full bladder tends to displace the uterus and the ovaries from the probe. It is important to note, however, that the high ultrasound frequencies that we work with when we perform a vaginal scan usually cannot penetrate far into the body. So we cannot see abdominal organs above the pelvis. An understanding of this physics of frequency and depth has determined the transducer choice in gynecological ultrasound examination. And the conclusion is that large pelvic masses, like huge uterine fibroids, or large ovarian masses of the pelvis, the transvaginal approach, which is superb resolution and closer to pelvic organ, is the preferred approach to perform the gynecological ultrasound. In the case of virgins, a transrectal scan should be performed. All of you are familiar with this image. You see the operator or the imager on the right side of the patient, standing or sitting, facing the patient and facing the ultrasound scan machine. You can all see how much privacy this procedure requires. So please avoid too many people in the room. Change the woman to a gown or give her a spreadsheet as much as is possible. You must always have a chaperone when you perform, even if you're a woman. And your chaperone should not stand at the foot of the bed. Should stand at the side of the bed with you taking notes or at the head of the bed. The position in which we perform the transvaginal scan is supine, as in pelvic examination. One aspect that we tend to forget in our rush to insert the probe into the vagina is counseling of the patient. Please ensure that you check that is the correct patient that we are scanning by checking the patient's name, confirming the age or date of birth or hospital admission number. At least it is recommended that at least 2 of these identifiers must be inputted into the ultrasound scan machine to enable image archiving. Allay the fears of the patient by describing the purpose of the examination and then explain how the examination will be performed. Never forget to get an acceptance to perform the procedure from the patient. Now, hygiene is important, extremely important that we consider hygiene when performing transvaginal scan. Probe infection, proper probe disinfection is essential and must be done before every use in accordance with standard guidelines. Remember, I'm sure you're aware that it's in evidence that infections like hepatitis B, human papillomavirus, and chlamydia trachomatis, even HIV, have been reported to have been contracted through the transvaginal scan. So commonly, we use low-level disinfection using quaternary ammonium compounds containing wipes like baby wipes to clean the probe. Always ensure that this is done before and after every use. So we perform the scan, we wear gloves initially in both hands, and then we clean the probe as we have just described, and then we pour gel in the latest sheet, usually the condom, and then insert the transvaginal probe into the condom. Remember to lubricate the tip of the condom, lubricate the tip of the probe before inserting it into the vagina. Hold the probe with your right hand always. Even if you are left-handed, we perform the transvaginal scan with the right hand. As we have discussed, stand or sit by the right-hand side of the patient. Never, never between the thighs of the patient. Remember to tell the patient, I want to insert the probe. Pat the labia with your left hand, remove the gloves on the left hand to enable you manipulate the machine and optimize the image continually as you perform the scan. Before we start, it is always important for us to refresh our anatomy and to remind ourselves of where we expect to find things. In terms of the layers that we pass through when we perform the transvaginal scan, we have the anterior to the posterior section. Here, moving from anterior to the posterior, we have the symphysis pubis here. We have the bladder of the right just posterior, and then the vagina just below, up to the cervix, upward, and then the uterus. Behind the uterus, you have the bowels, the rectum, and the lumbosacral spines. Always remember this picture when you pick up an image of a transvaginal scan. So at least one thing really, to be honest, one thing I want you to take away from here, the most important thing really is for you to have a systematic examination technique using the same procedure always. Always perform your scans in exactly the same manner, looking at all the organs in exactly the same order. Why? Because if you do not apply a systematic scanning technique, you introduce your probe into the vagina, you see a large ovarian cyst, you become extremely excited about the cyst, and you scan the cyst for several minutes. And when the woman has left the room, you realize that you did not scan the uterus and you did not scan the other ovary. That would not happen if you apply a systematic scanning technique. Again, if you apply a systematic scanning technique, you build up in your brain a reference for what is normal. Therefore, in distinguishing it anytime you see the abnormal. So it is recommended that we perform our scan in a systematic way, beginning by viewing the vagina, the pelvic floor, the cervix, the uterus, and the ovaries in that order. But we need to understand that there are standardized probe orientations and probe movement to perform this from the point where we insert the probe in the vagina. Before this, you know about how to lubricate it. Remember to lubricate the tip of the probe. So we're going on to the anatomy, refresh your anatomy. You all have a clear understanding of anatomy. You know that the symphysis is in front and the sacral spines are behind. So here we talked about the fact that you should have a systematic scanning technique using the same procedure always. Always perform your scans in this, looking at all the organs in the same, always perform your scans in the same manner, looking at all the organs in the same order. Why? Because if you do not apply a systematic scanning technique, you introduce your probe into the vagina and you see a large ovarian cyst. You become extremely excited about the cyst, so you scan the cyst for several minutes, and when the woman has left the room, you realize that you did not scan the uterus and you did not scan the other ovary. That would not happen. Again, when you apply a systematic scanning technique, you build up in your brain a reference for what is normal. By this, you'll be able to distinguish it from the abnormal anytime you see it. So it is recommended that we perform our vaginal scan using a systematic technique, viewing the vagina and the pelvic floor first, and then the cervix next, then viewing the uterus and the vagina, always in that order. But you should be aware that there are standardized probe orientations and standardized probe movement to achieve this goal, especially as the vagina is a small cavity and the vaginal scan an extremely sensitive subject. So you are looking at this slide, and in the slide you have the transducer marker identified by the arrow, usually an indentation on the probe or an elevation on the probe. So identify the one in your own probe, and with the marker, the transducer marker at 12 o'clock as shown on this slide, introduce your probe into the lower vaginal canal, avoiding the sensitive urethral area. Do this under direct vision, please. Slide the probe further into the vagina, maintaining this orientation. Now, regarding transvaginal probe orientation, there are only two probe orientations possible. On this picture, you have the first picture here to A. You have the transducer marker anteriorly, and then with your probe at the 12 o'clock position, the transducer marker at 12 o'clock. When you rotate the probe anti-clockwise, turning the transducer marker to 9 o'clock, you have a different probe orientation. So two probe orientations are possible. Transducer marker at 12 o'clock, you acquire the longitudinal image. rotate the probe so that the transducer marker moves to 9 o'clock, you acquire the transverse image. Never move the probe to 3 o'clock, you have a wrong image. And so here we are with the transducer marker. Here we are with the transducer marker at 12 o'clock, anteriorly there. You have the longitudinal view. You have the longitudinal view. And on ultrasound, the image that you see is what is shown here. You see an anteverted uterus. You see an anteverted uterus with the fundus cephalad and the cervix chorda. Now interpret it with the human picture just inserted there, and you see that this is the anterior aspect and this is the posterior aspect. Something I think we need to discuss, and quite important, is that there is, on every transducer, you have the probe marker, or the transducer marker, which is in this screen here at the 12 o'clock position. All transducers have a corresponding marker on the ultrasound scan machine. If you put a gel at the tip of the transducer and you touch the transducer, you will see some activity on the screen. Wherein that activity is the position of the corresponding orientation. In this screen, you see a circular red mark on the screen in the image on the right, showing you the logo of the machine, position E8. That is the corresponding marker, orientation marker on the screen. Usually, this orientation marker is on the top left-hand corner of the screen if the transducer marker on your probe is anterior and at 12 o'clock. This is important. Now, we have talked about our gross anatomy. Let us look at ultrasound anatomy. Here again, sorry, I'm trying to use my cursor to just direct movement here. Here on this screen, we see the cervix, like I mentioned, chorda in the previous slide, in continuity joining the endometrium. The endometrium is hyperechoic in this image, contrasting with the hypoechoic myometrium. We have talked about the position of the fundus lying chorda, cephalad, and the bladder lying anteriorly. Again, we have the rectus sigmoid colon posteriorly. Memorize this image. It is helpful with image orientation, with pattern recognition. Pattern recognition. A dog is a dog because your mother told you so. So here, this is a pattern that you will recognize anytime you see an anteverted uterus. Again, we rotate the probe. When we rotate the probe such that the transducer, rotate the probe such that the transducer marker moves to 9 o'clock position. The image that you see on the screen is a transverse view of the uterus. And again, you need to recognize this anatomical relationship. The right is as shown here on the left side of the screen. The left of the image is as shown here on the left of the screen. Superior is up and inferior is below, in just a position with the human image shown on the left of the screen. Now, why is orientation important? Because if you do not appreciate orientation, you would report a left-sided fibroid, a left-sided mass as right-sided, and you would report an anteverted uterus as retroverted, and you will report an anterior fibroid as posterior, making it difficult for the laparoscopic surgeon, for example, to actually pick up the image. So we'll discuss this in further as we get along. Now, we go to probe movement, the basics. We have mentioned the transducer marker continuously. We said it is either an indentation or an elevation on your probe. This is basically where you're likely to find it, and it is usually anterior at the 12 o'clock position, if you hold your probe in that position. Now, regarding probe movement, usually in the longitudinal plane, movement is only horizontal, moving from side to side, right side to left side. Usually in the transverse plane, movement is anteroposterior, moving upward and backward, upward and backward. These are basic probe movements. In both planes, movement is rotational. Remember, anti-clockwise, from 12 o'clock to 9 o'clock and back. These are basic probe movements. Now to the final point. When the first movement, usually, when we introduce the probe into the vagina and aim to advance it, is called sliding movement. This is the movement along the length of the vagina, necessary to view the entire pelvis and to focus on particular images. The arrow on the screen shows us that the movement, shows us the direction of movement, which is along the axis of the probe. The probe and the sliding movement traditionally is in the anteroposterior direction with the transducer marker. The movement we make with when we capture a longitudinal view of the pelvic structure is called panning. Movement from side to side, horizontal movement from side to side. The arrow shows the direction. When you move the handle of the probe to the right side, the tip of the probe moves in the opposite direction. This movement allows us to view lateral structures, so panning movement. Again, we rotate. We move from the 12 o'clock position to the 9 o'clock position anti-clockwise. The arrow denotes the rotational or circular movement. This moves the image from the longitudinal view to the transverse view. Then we rock. The rocking movement is the movement, usually this movement is traditionally in the, with the probe at 9 o'clock. So we move the handle of the probe upward, anteriorly, as denoted by the arrow here, anteriorly, so that the tip of the probe moves downward. And then when you move downward, the tip of the probe moves in the opposite direction. The movement allows us to explore the transverse image of the uterus and is pivotal in scanning the ovaries. Now it's important to note that slight rocking movement with the probe with the transducer marker at the 12 o'clock position is called teething. Slight rocking movement with the transducer marker. Back. All right, sorry, it appears I was lost. So but I was talking about rotating movement. We have described that. And now we're talking about the rocking movement. And we said the rocking movement is traditionally with the probe facing 9 o'clock position, the transducer marker facing 9 o'clock position.
Dr. Agholor?
Yes, Chief.
We have run out of time. As I said at the beginning, I knew obviously that we had taken too much bite for today. I'm sure you still have a few more slides.
Chief, I have slides.
I know. So what's going to happen is that we're going to stop at these basic movements. We are going to replan this thing again. I think I'm going to have to replan some of these things to make sure that we have enough time for a particular subset. So after rocking, I think rocking is one of the last basic movements.
Let me stop at this point.
All right.
So that at least the basic movement will be clear to all.
Yes.
If I stop, let me stop at this slide I just posted now, abdominal, the orientation, that's it, I can stop there. Okay. So I have like 3 more slides to present, that's it.
Okay. Now, those other sliding movements, those are for abdominal, right?
No. We just, that's about the orientation of the image and how to, but let me just finish the slide and then I can stop there.
Okay, all right, move on.
So I'll stop
just 2 minutes
before this point.
Okay, good.
This was to just talk about the orientation and for them to understand how we orientate ourselves when we scan. And what? I lost me.
Next speaker, who is a guru, a super guru actually. He is an obstetrician gynecologist from the University of Maiduguri.
Before we discuss the pathology, it's important for us to remind ourselves about the normal ovary. Now, the compositum, as we are all aware, is also part of the normal ovary. But because it is a great sonographic mimic, it's important for us to create a niche for the compositum so that we appreciate the appearances of the normal compositum. The commonest cysts encountered in clinical practice are the functional cysts. Interestingly, hemorrhagic cysts are usually reported as complex cysts. And this is one thing that disturbs me a lot when I see a report of complex cysts. What is complex? Just describe the size in 3 dimensions. Describe the appearance. And apply color if you have one, rather than telling us a complex mass. Because what is complex? Any tissue or cyst that has any echogenicity within is considered as a complex mass. And there are many complex masses encountered in clinical practice. And unfortunately, a few will go under the knife of the surgeon because of the report of the complex cysts. And this cysts can resolve without treatment. Then we look at the benign cysts, from dermoid cysts, endometrioma, cystadenoma, and fibroma. Well, fibroma cannot be said to be common, but since it's the commonest solid benign tumor, to me it's common. When we talk about the adnexal, we are not referring only to the ovary. The tube is also part of the adnexal. The broad ligament is also part of the adnexal. So we are going also to look at the classic ultrasound features of some extra adnexal pathologies, extra ovarian adnexal pathologies. The learning objectives for this webinar is for us to be able to confidently differentiate physiologic from pathologic ultrasound scan findings. And most importantly, to use pattern recognition to be able to define the common pathologies seen in the adnexal. All the images for this presentation are cases managed in the Department of Obstetrics and Gynecology of University of Maiduguri Teaching Hospital. Now, if you see this footprint with a semilunar appearance, it tells us that it is a transvaginal prop. This tells us that it is a curvilinear prop. Now, before we go further, it's important for us to remind ourselves about the standard descriptions, definitions, and terms by IOTA. There are many other classifications, but this one stands out and is validated. So that's what we are going to use for the purpose of this webinar. Adnexal lesion, by IOTA definition, is any ultrasound assessment which is inconsistent with normal physiological function. For example, if you have a persistent unilocular cyst, a persistent unilocular cyst is inconsistent with normal physiology. What is consistent with normal physiology is for a dominant follicle to be dilated, it matures, ruptures, and transforms into a compositum. That is what is consistent with normal physiology. So if a cyst persists and fails to rupture, it's a lesion. Compositum has several appearances, from cystic, hemorrhagic, to solid. So if you see a solid compositum in the adnexal, it is not a lesion because compositum is consistent with normal physiology. This is an example of a persistent irregular cyst. So this is an adnexal lesion. A septum is a thin strand of tissue that runs from one end of the cyst wall to the other. It can be complete, as in this case of endometrioma, or incomplete, as in this case of hydrosalpinx. When you say a tissue is solid, that means it exhibits high echogenicity. High echogenicity suggests the presence of tissue, like a fibroma, as you can see in this case, a myoma, myometrium, or the ovarian stoma. When you see appearances like this, this depicts the presence of solid tissue. When there is a doubt as to whether what you are dealing with is a solid tissue or blood clot, there are two things you can use as far as IOTA is concerned. You can use the transvaginal probe and push the lesion. If the content moves or jiggles, it suggests that what you are dealing with is blood clot. If you apply color and it tells of blood color, it tells you that it is solid tissue, not blood clot. Aorta emphasizes the use of transvaginal ultrasound scan. But I can tell you, in our practice in developed societies, if you rely solely on transvaginal ultrasound scan, you run out of business. Why? Because the majority of our patients present less, and the masses are far away from the view of the transvaginal probe. And that is why what I do is, first of all, to do a transabdominal ultrasound scan, have a panoramic view of the pelvic structures before doing a transvaginal ultrasound scan. A solid papillary projection is any solid. You can see I bolded the solid. It's any solid projections into a cyst cavity from the cyst wall, which measures greater than 3 millimeters. When it's measured less than 3 millimeters, it is called wall irregularity. This is an unfortunate lady, 25-year-old, with advanced ovarian cancer. So you can see these are papillary projections because they are solid tissues. They can take up blood color, and the measurement is greater than 3 millimeters. Now, this is a case of endometrioma. This is a case of endometrioma with the ground glass appearance. You can see something that looks like a papillary projection with cauliflower appearance. This is not a solid tissue. This is slush, and it shouldn't be considered as solid tissue. If you are in doubt, apply color. This will not take up color. Acoustic shadowing is loss of acoustic echo behind a sound absorbing structure. As you can see in this case of dermoid, here you can see this acoustic shadow. Here you can see another one. For beginners, it may be difficult to pick this, but look at this acoustic shadowing. Even for a beginner, this is easily discernible. So this is the case of dermoid cyst. When there's fluid outside the portion of Douglas, it is considered as a cyst. This is a case of advanced ovarian cancer. You can see deposits in the rectal sigmoid, deposits in the fundus, deposits in the intravesical pouch. The uterus is literally flooded. So this is the definition of ascites. Now, color score is classified into 4. Color score of 1, no flow. Color score of 2, mild flow. Color score of 3, moderate flow. And color score of 4, abundant flow. This is a case of cirrhosis adenoma, so we don't expect color flow. The color flow is 0. This is a polycystic ovary, and in polycystic ovary, the stroma has a high blood supply than the normal ovary. This is a case of adult granular cell tumor, and this is the color flow we expect. And this is a case of choriocarcinoma. By aorta classification, ovarian tumors are classified into 5. Unilocular cysts, unilocular solid, multilocular cysts, multilocular solid, and solid tumors. A unilocular cyst is a cyst without septate or any solid part or papillary projections. A unilocular solid cyst is a unilocular cyst with a measurable solid component or a papillary projection. A multilocular cyst is a cyst with at least a septa without any measurable solid component. A multilocular solid cyst is a multilocular cyst with a measurable solid component or a papillary projection. A solid tumor is a tumor where the solid components comprise 80% or more of the tumor when assessed in 2-dimensional section, as in this case of adult granular cell tumor. You can see as surgery, it's more than 80% of the tumor is solid. Not classifiable because of poor visualization, as we have seen in that case of dermoid cyst. These are the other classifications, but as I said earlier, what stands out is the aorta classification. Now, the normal ovary is like desert dead. It's ovoid in shape, and not just the ovary. Any mass must be measured in 3 orthogonal planes. What is important as far as assessing the ovary is concerned is the morphology rather than the volume, because the volume changes with the menstrual cycle. Occasionally, there will be challenges locating the ovaries, especially in prepubertal girls and in postpubertal period. What makes the ovaries desirable are the follicles. For the pubertal, the follicles, the ovaries are quiescent. Postmenopausal, the ovaries are retired, so to speak. So in this case, you can use the iliac vessels to locate the ovaries, as in this case of a postmenopausal patient. So the iliac vessels actually serve as a GPS for locating the ovaries in difficult cases, not just in prepubertal girls or in postmenopausal patients, even post-hysterectomy. Iota described 5 cyst contents: anechoic, low level, ground glass, hemorrhagic, and mixed echogenic. And these are examples of each. Anechoic, the content here is clear, no debris. Here, low level echoes, as in cyst adenoma, you can see the low level echoes here. Then here, because the particles are dense, it appears as ground glass, typical of endometrioma. Hemorrhagic compositum, you can see these fibrin strands, and mixed echogenicity as in dermoid cysts. And here you can see another dermoid cyst with fat fluid level. For those of us who do transvaginal ultrasound scan, the Rotterdam criteria as regards to 12 follicles is in contention. But what is not in contention is the thick stroma. This patient's testosterone level was 3 nanograms per deciliter. His suite had cleitomegaly and failed colostomy therapy. Now, this is the same patient who has the peripheral type of PCO in one ovary and generalized in the other ovary. This is a patient who presented with oligomenorrhea, patient presented with infertility. Now, what is important here is to be able to differentiate between multicystic ovary and polycystic ovary. In multicystic ovary, the stroma is usually thin, commonly seen pre-puberty, during lactation, and in women with hypothalamic amenorrhea. Why did we create a niche for corpus luteum since it is not a lesion? This is because corpus luteum can actually masquerade as endometrioma, as an abscess, as a neoplasia, or ectopic pregnancy. This is a freshly prepared, so to speak, corpus luteum. This is a baby corpus luteum. If you follow through the walls here, you can see that the walls here are smooth, but somewhere here you see some irregularity, suggesting that this is the area of follicular rupture. When you apply color, you see this typical ring of fire appearance. This ring of fire appearance usually appears within 48 to 72 hours after follicular rupture. So if you apply color before then, it's unlikely for you to see color flow. When you do the spectral Doppler, the resistance is usually low for early corpus luteum. Much later, the resistance will increase. This is another corpus luteum. You can see the thick walls here. You can see the anechoic content, and you can see the irregular area here, suggesting the area of follicular rupture. Area of follicular rupture usually is seen within 1 week of ovulation. Beyond that, it's difficult to see. So one can guess the age of the corpus luteum based on this. Now, this corpus luteum appears as a solid structure, as you can see, solid structure. So this could be mistaken for a lesion, but this is not a lesion because this is consistent with normal findings. And of course, we are told that the corpus luteum is the organ with the highest blood supply in the body, as you can see here. Functional cysts are the commonest cysts encountered in clinical practice. This is a corpus luteum cyst. This is a follicular cyst. You can see the content, very clear content, good sound transmission, thin walls, no septum. In fact, I prefer the subclassification of ORADs of simple cysts than the unilocular cysts of iota. Why? Because, I mean, if you say someone has a simple lifestyle, what does that mean? No Rolex, no Gucci, nothing. He lives a simple life. So a simple cyst, as the name suggests, is simple. Thin wall, clear content. These are the commonest cysts encountered in clinical practice. Most of these cysts will disappear within 6 weeks. Most of these cysts will disappear within 6 weeks and they do not require any intervention. Corpus hemorrhagic. What is important to stress here, early hemorrhagic cyst appears as a solid mass. So it could be mistaken for a solid ovarian tumor. But one way you can differentiate between a cystic structure and a solid structure is that cystic structure gives good sound transmission or good distal enhancement. Solid tissues do not give good distal. In fact, they don't even give distal as enhancement, except if there are cystic components within the solid tissue. Hemorrhagic cysts will not take up color because they have no blood supply. So the color score will be 1. It gives when moved with the Prof. Hemorrhagic cysts, just like follicular cysts, are usually unilocular. I just avoid using the words always, but they are nearly always unilocular. Both follicular cysts and hemorrhagic cysts are almost always unilocular cysts. Now, people describe corpus hemorrhagicum variously as honeycomb appearance, copper appearance, fishnet appearance, or thread-like. Now, this is a hemorrhagic cyst, and generally, hemorrhagic cyst transites from clot formation to clot lysis to retraction and resolution. Now, one could mistake this for a solid structure. But remember, one of the distinguishing features between cystic and solid structures is that cystic structures give distal enhancements. Now you can see the distal enhancement here. So what this suggests is that most of the content here is fluid. ORATs describe retractile clot as a vascular echogenic component with angular, straight, or concave margins. Now, if you look at this cyst, it contains some echogenic areas, some fibrin strands, and some anechoic areas. But somewhere here, you can see an echogenic area. So this corpus hemorrhagicum is in the process of clot retraction. All these patients presented with abdominal pains, all of them have corpus hemorrhagicum. I'm here to see a case of corpus hemorrhagicum with a thin wall. All the ones I've seen so far have thick walls, as you can see in this image. Now look at the content here, looking like thread-like. Here you can see thread-like content. Somewhere here you can see clot retraction. Here again, behind this measurement, you can see retractile clot. Again, fibrin-like strands. This is another case of retractile clot. Now when we play this video, you will see that it jiggles. See that? It jiggles on Prof movement. Now I want to emphasize this use of transvaginal ultrasound scan, but this is a transabdominal ultrasound scan, but the fundamentals are the same. Apply pressure and the content will jiggle if it is blood clot. Now, as we said earlier, blood clot does not take color. So if you see here, you can see it does not take color. So this is motion artifact, not color for because of the Prof movement. This patient presented the first trimester with abdominal pains of 2 weeks duration and dizziness. And she came with an ultrasound scan report of a solid ovarian tumor. Of course, when the resident came with the report, I thought it was a malignant tumor. But when we repeated the ultrasound scan, now you can see this mass sitting in the pouch of Douglas. Now look at this sound transmission. So this suggests to me that most of the content is fluid, not solid. And again, if you look at the lower segment here, there is subchorionic hematoma. So this patient probably has a bleeding tendency. Now, this is where color flow can be quite helpful if you are in doubt. Now, when we apply color here, you can see the corpus luteum here is solid, or you can see this ring of fire. You can see that there is no blood flow here at all. Why? Because this is blood clot. And blood clot will not take up color. The color score will be 1. So, I mean, we managed this patient conservatively, and she continued with her pregnancy and had a successful vaginal delivery. Now, this is a dominant follicle. You can see the walls of the follicles, the content very clear. Much later, in about 50% of cases on transvaginal ultrasound scan, you can see this cumulus ovarus. And somewhere here, you can see the separation of granular cells from the theca cells. These are features of eminent follicular rupture. And if you look at the cervix here, you can see the cervical mucus is clean, it's clear. This is where you demonstrate the spin bucket. So you can see the feature here is consistent with what you have here. So to me, actually, this appearance is like the ultrasound scan equivalent of LSH, because 24 to 36 hours after the appearance of cumulus, the ovulation will take place. Now, if you follow up this patient, and you see there is more separation of the theca cells, but there is no rupture, you can make an assessment of luteinized ruptured follicle. The follicle, this is fresh ovulation, the one I showed earlier, not from the same patient anyway. At times, we could misdiagnose blood clot for a papillary projection. But remember, history is extremely important. You cannot report the ultrasound finding without having, especially the age of the patient and the presenting complaint. These are the least information that we need to obtain to arrive at the reasonable ultrasound scan diagnosis. This is hemorrhagic cyst, and this is blood clot. It's not a papillary projection. This is a papillary projection. If you are in doubt, apply color. This will take up color with the proper Doppler settings, but this will not take up color. Now, these are fibrin strings in the case of should not be confused with septate in cyst adenoma. Now, let's look at the common benign adnexal tumors. The commonest seen in women in their reproductive age is dermoid cysts. Then we look at endometrioma, cystaderma, fibroma. Any of these can undergo torsion. So it's not out of place for us to also look at the ultrasound appearances of ovarian torsion. Dermoid cyst generally is a solid cystic mass. Usually, dermoid cyst has echogenic areas of hair, fat, or calcification and shadowing. These are the three features that are peculiar to dermoid. Once you see these features, there's no need to query. What you are dealing with is dermoid. I'm yet to see a dermoid cyst that has no echogenic component. I've seen a case of dermoid that is not cystic. So I began to wonder, why is it called dermoid cyst? I've seen cases that do not contain cystic components. I've seen dermoids that do not have calcifications, but I'm yet to see dermoid that does not contain any echogenic area. So to me, the key in making a diagnosis of dermoid is an echogenic area in the adnexal. In the majority of cases, we do not need more than a grayscale to make a diagnosis of the common benign adnexal lesions. In 90% of cases, with a grayscale, we will make a diagnosis of the common benign adnexal lesions. Occasionally, there will be challenges in the ultrasound appearances of dermoid. It may overlap with hemorrhagic cyst or with endometrioma. If we have such a scenario, never give an absolute diagnosis. All you need to do is describe the size, the appearance, put up color, and give out your findings. The physician has taken history, examined the patient, so you can tie your ultrasound scan findings with the history and examination and arrive at a reasonable diagnosis. This is not a gynae scan. This is an obstetric scan. This is a fetal head, as I'm sure we all not these bright dots and lines here. And again here, not these bright lines and dots. So if you see this on an obstetric scan, will you doubt the fact that this is fetal hair? If you will not, then when you see something like this in the adnexal, don't doubt the fact that it is dermoid cyst, because that's what it is. Dermoid is the commonest benign tumor in children. And we have 3 examples here. 10-year-old, you can see this well-circumscribed cyst. Look at this good sounds transmission. Here you can see an asymmetric wall thickening. This is a feature of chronic torsion. No wonder this young girl presented with recurrent lower abdominal pain. Now, somewhere here you can see an echogenic area. Again, here you can see an echogenic area. At surgery, you can see areas of calcification. So once you see an echogenic area in the adnexal, and you make a diagnosis or an impression of dermoid, you are more likely to be right than to be wrong. Here's another case of dermoid. Look at this line, dot, dash, dot, dash. There's nothing to query here. This is hair. You can see this is fat, or you can see dot, dash within the fat, and this is a fat ball. Somewhere here you can see follicles, you can see ovarian tissue here, and you can see a halo between this follicle and the cyst. This suggests that this cyst will be easy to tease out at surgery, and of course it was easy to tease out at surgery. And look at the content of surgery. Look at here, the fat, the cartilage. This is a rare appearance actually of dermoid, having these lipids materials dispersed within the cysts. This is the first case I've seen so far. This is the case of a dermoid. You can see fat fluid level. Here you can see another fat fluid level. You can see adhesions between the larger cysts and the fundus of the uterus. Here you can see this cyst wall is thick. Of course, at surgery you can see the cyst wall is thick. Look at this fat globule at ultrasound scan. Here is it at surgery. Now look at this second dermoid, which we thought was the second dermoid, but at surgery we realized that it was a loculation of pus. We took the samples and sent for cytology, and it came out to be purulent. So if you have not followed these patients, as far as we are concerned, our report will be multilocular dermoid. So it's extremely important to follow up patients. Extremely important. You learn a great deal when you follow patients. Now, if you look at the contents of this cyst, it appears ground glass. So not all ground glass appearances are endometriomas. This patient presented in the second trimester with abdominal pains. On ultrasound scan, you can see this well circumscribed cyst, very good sound transmission, but you can see an echogenic area within the cyst and another one here. So if you see an echogenic area in the ovary and you make a diagnosis or an impression of dermoid, you are more likely to be right than to be wrong. She presented 2 years later with worsening abdominal pains, and this is the repeat ultrasound scan. Here you can see the content of this fluid is anechoic. This is surprising because when you have a fat tissue here, what you expect is that some will disperse and the content of this will not be clear. But what this tells me is that this fat globule is contained within its own capsule, and that is why this cyst is anechoic. And of course, that was what we found at surgery. You can see the capsule of this fat globule. Now, in the other ovary, you can see the outline of the other ovary here. We saw a ring, an echogenic ring within the substance of the ovary. This is one thing that laparoscopy cannot pick. When you see an echogenic area in the adnexal and you suspect dermoid, you are more likely to be right than to be wrong. This is the ovary at surgery. When you cut it open, look at the dermoid balls. Yeah. Same patient presented 3 weeks after surgery with abdominal pains. So you can see hemorrhage. 4 weeks later, the hemorrhage is resolving. We are told that dermoid is bilateral in about 10 to 15% of cases, as you can see here, bilateral dermoid. If you look at this again, this fat lobule is contained within its own capsule, and that is why the content of this cyst is clear. So this is this fat you can see here. Here you can see the dot dash pattern, and you can see here particles here within the cyst wall. So once you see the dot pattern, please do not query. It is likely to be dermoid than anything else. This is Rokitansky nodule, where you have fats here and calcifications. Here is a fat globule, but this is reverberation artifact. Dot dash pattern here, areas of echogenicity. You can see the tip of the iceberg sign. This is fats. You can see the echogenicity of the fluid. You can see dot dash pattern here, suggesting the presence of fat. And here you can see echogenic acoustic. What is interesting about this case is that the cyst is located in the uterovesical pouch. One of the key features of ovarian torsion is malposition, but this patient did not present with lower abdominal pains. This patient presented in the second trimester. You can see the placenta here. You can see the uterine wall. It's difficult to differentiate the uterine wall from the wall of the cyst. So this suggests that there is adhesion here. Here you can see dense adhesions. Now the contents of this cyst is neither here nor there, but you can see what appears like dot dash pattern here. But what gave it away is this echogenic ball. And fat, we know, is lighter and it floats. So this is what gave it away as dermoid, not disappearance. As surgery, you can see the dense adhesions. Yeah, look at the cyst. When it ruptured, the content was pus. So it was a case of an infected dermoid, but we didn't make that diagnosis earlier on. So when I went back and looked at this image again, I realized that yes, this is not typical. So probably that is why we missed it. So but because we follow the patient, it's easier for me now when I see something like this to query infected dermoid, especially if I obtain his history of lower abdominal pain from the patient. Now this same patient we've seen earlier. We just try to play around with a 3D. So you can see the wall here is smooth. You can see the fat content. You can see the calcifications. Inversion mode tells us that yes, most of the content is cystic. But if you look at it critically, you realize that what additional information did we get actually from this 3D that we couldn't get from the 2D? Not much really. So you don't need a 3D or you don't need a Doppler to make a diagnosis of most of the benign adnexal lesions. For many of us who grew up in the villages in the 70s and 80s, I believe we remember this appearance. So if you see something similar to this in the adnexa, it is likely to be an endometrioma. This is what is called the ground glass appearance. If you see some echogenic wall foci, also called calcific stippling, it is more specific of endometrioma. So if you see a ground glass appearance in the adnexa and calcific stippling, there is no point querying endometrioma. That is what it's likely to be. But if the question is postmenopausal, be careful, it could be an endometrioid carcinoma. This is a case of endometrioma, followed up and had surgery. So look at the ground glass appearance. This is sludge. You can see it's ugly looking, appears like papillary projection, but this is sludge and it should not be reported as papillary projections. It is sludge. The same patients. Here you can see fluid level below at different stages. You can see the ground glass appearance here, and you can see adhesions here between the uterus and the endometrioma. I'm here to see a case of an endometrioma without associated pelvic adhesions on ultrasound scan. I'm here to see one. This is a virgin, a 25-year-old, who presented with vulval swelling, which turned out to be a vulval endometrioma. So not all vulval swellings are Bartholin's abscess or Bartholin's cysts. She had no other complaints. But on examination, we found a 16-week size mass. And on ultrasound scan, you can see this typical ground glass appearance. Now here you can see the right endometrioma here, the typical ground glass appearance. Then you can see here the left endometrioma. You can see the ovaries are close together. So this is what is called kissing ovaries. Kissing ovary is a sonography soft marker for adhesions. So once you see kissing ovary, that tells you that there is severe adhesion. And actually that was what was found at surgery. If you look at these echogenic areas, they appear to be around the region of the ligaments. Now here you can see an equal to sign, echogenic sign within the wall of the cyst. So if you see a ground glass appearance and this echogenic wall foci, in all probability you are dealing with an endometrioma. Now if you look at it closely, you realize that the ovary here is actually plastered to the posterior wall of the uterus. And here you can see the right endometrioma is actually adhered to the fundus of the uterus. So this is more like a frozen pelvis. If she was not a virgin, when you apply pressure upwards, the uterus will not slide over this mass. Both the uterus and the mass will move together. So that tells us that the sliding sign is negative. And that is also a feature of adhesions. Now, this appearance is a ground glass appearance, another ground glass appearance here, and another one here. Now, this is a case of transvaginal septum. This is a transrectal ultrasound scan. You can see a case of hematocorpus. This is the same patient with hematometriocorpus. So not all ground glass appearances are endometriomas because the contents of hematocorpus and endometrioma are the same. So the ultrasound appearances will also be the same. These are other patients with bilateral endometrioma. You can see the ground glass appearance. You can see the echogenic wall foci, and this is the finding at surgery. In the course of this operation, the cyst ruptured, and you can see the chocolate content, and that is why some call it a chocolate cyst. Cyst adenoma can be unilocular or multilocular. Serous cyst adenomas are usually unilocular, and the contents are usually clear, anechoic. Mucinous cyst adenoma are usually multilocular, and the contents are not usually clear. They have low-level echoes. The septations are regular with no focal thickening. This is a case of mucinous cyst adenoma. You can see the contents, low-level echoes within the cyst wall. But you can see that it's unilocular. So it's not all the time that mucinous cysts are always multilocular. This is a mucinous cyst that is unilocular. So you can also have serous cysts that are multilocular. Now, as I said earlier, I have not seen a case of endometrioma without associated pelvic adhesions. So at times, if you are in doubt as to whether it is a cyst adenoma or an endometrioma, you can apply pressure here. When you apply pressure and you see a movement of these particles towards the other end, that is called streaming, and that is a feature of endometrioma. Because of the thick particles I beg your pardon, is a feature of cyst adenoma. In endometrioma, because the particles are dense, they will not stream. So this is one way you can differentiate between mucinous cyst adenoma and an endometrioma. And again, if you follow this wall, you can see that there's no adhesion. This cyst is just sitting on the fundus of the uterus. This patient presented 7 months after delivery with abdominal pains, and she was found to have a mass that was equivalent to 36 week size. You can see the contents very clear. It was a case of serous cyst adenoma. It weighed 8.3 kg, and we emptied about 50 liters of structural fluid. This patient was admitted in surgical ward with query acute and chronic appendicitis. When they did an ultrasound scan, they found an ovarian cyst, and she was referred to us. When we depict the cysts, you can see the cysts here, good sound transmission with this locus, thin wall locus, numbering 6. And here, of interest here, is this asymmetric wall thickening. When you see an asymmetric wall thickening, it suggests probably that the patient has chronic torsion. And that was what we found at surgery. And it turned out to be mucinous cyst adenoma. As I said earlier, fibroma cannot be said to be a common tumor, but it's a common solid benign ovarian tumor. This patient was a 43-year-old presented with lower abdominal pains. Now look at this within this solid component, and you can see the crescent sign, which suggests that this is intra-ovarian. You can see the solid nature, and somewhere here you can see the fimbriae, because there is ascites, so the fimbriae is visible because of this. Now here you can see the lobulated nature of this mass. You can see the shadow here, and you can see the color score here. In the literature, the color score is usually for 1 or 2. But here you can see this color score is more than 2. But what I think is that because of this adherent tube, the color uptake here is from the blood supply to the tube and not to the fibroma. So to me, I believe that this is the true color score. Now, this is a case of pedunculated uterine fibroid. You can see this echogenic area here, You can see it has a smooth wall, the same thing here, but this one is lobulated. You can see this stripy shadowing here. So it's actually difficult sonologically to differentiate between the fibroma and uterine fibroid. But again, you can actually trace the origin of a pedunculated fibroid from the uterus. You have any doubt, apply color, you see the pedicle floor, except perhaps in cases of parasitic fibroids where there is no connection. But in that case, the fibroid will be different actually from the ovary.
Excuse me, Dr. Bukar.
Yes.
I have to beg. I know that it's a very tough one. I already saw this that we're going to obviously overshoot. We're almost at 4:30, and I'm going to plead. We are going to we'll have to work on having to repeat some of these things. The attendance today has beaten previous records, and therefore means that it's something that people are very interested in. I don't know if I can plead with you that we stop at this stage, because I see that we still have at least 3 major things to look at: hydrosalpines and a few other things. I hope you don't mind.
Okay, that's okay.
Okay. I'm very sorry, because I know that preparing some of these things with all the slides, and it's good for everybody to know that these are all indigenous slides. There's no slide here that was taken from a textbook. They were all transferred to his textbook anyway. So, I mean, it's really fantastic. All I want to say is that let's give a thumbs up, a clap. You all know how to use it on your system. Just go there and give a clap to the presenters that we have today.